Hi everyone. So obviously, whenever there's an INA exam, the most difficult part is how to navigate the general medicine portion. Specialty, you know where to study from, you know how much to study, what to study. You have your sources, you have your strength as well. That you basically bank on those specialty questions. But the general medicine portion is difficult because it's vast. At the same time, it's not so much of a weightage. NEET SS, it's clear cut. These many questions come and it's the entire thing, but here the weightage is less but the vastness of it is very high, so it's a little bit difficult to prepare. But always what I tell is that always focus on your repeat questions and your repeat topics, at least that much, at least minimum the repeat questions. Yes, the last paper it was a little bit different. The general medicine portion was a little bit tougher than we expected and repeat questions were less. But before that, whatever 6 7 sessions have happened is usually pretty much repeat topic based, if not all. Like, we know that it's 30 questions of general medicine and 50 questions of specialty, and inside those 30 questions again you have around 4 to 5 questions of your specialty, depending on your specialty. If you're giving something like endo or cardio, maybe even you may have even more than five, right? So if you are focusing on those 25 questions, at least 10 questions always have been repeat questions or repeat topics. So if you get those out of the way, you are pretty much done. At least if you're doing mistakes in those also, then again your rank gets a hit, right? So we're doing one session for this, and we are mainly going to focus on your repeat questions. At least this much you should never get wrong. We're not going to go in depth because again each topic, if we start going in depth, that will take again 15 minutes each. So we're mainly focusing on the question, the answer and the solution, right? So, and also we'll at the end I'll try to give you a basic summary of rheumatology, what areas to focus upon. So this is how the pattern has been. From here itself you can kind of guess where the focus is on. As you can see, vasculitis is usually not as big a chapter, or even if you see your NEET SS, it's not so much focused upon, especially the recent NEET SS. But in your INISS, at least there is 1 to 2 questions of vasculitis that come, and that too, as we'll see ahead, it's more of a general vasculitis. It's not very much in-depth questions. SLE APS very much high yield, and these are the other distribution. When we finish all the question discussion, I'll tell you what areas to focus on. And in general, there are around 4 questions per session on average from rheumatology. So we'll go year by year. From the first INISS, we'll cover all INISS papers. I think there have been 7 sessions of INISS that have happened till now. Before that, there used to be separate exams, as we know. Now, INISS clubbed of all the institutes, all the institutes of national importance. There has been papers since November 2021, and those are what we'll be discussing. The first question is almost similar to what was recently asked in the NEET SS 2024 paper, but here if you see, it is just a patient sitting in flight extended, but there's a DVT that has developed in your proximal areas. Proximal DVT has developed. There is a history of 3 spontaneous abortions. CBC is normal, APTT is raised, rest autoimmune workup is pending. So this is a little bit tricky because here there has been no mention of your lab criteria, so you are not sure if this is an APS. So think about this from a general medicine point of view. If you're thinking about this from a rheumatological point of view, then you will go for lifelong warfarin. But here there's no mention of any lab tests specifically. There's no mention of any serological tests nor any mention of lac. Even if there was positivity of lupus anticoagulant, where you need 2 out of 3. You remember this revised Sapporo classification criteria, where inside the lupus anticoagulant you have 3 tests: BRVVT, silica clotting time, and prolonged APTT. Inside that you need just prolonged APTT will not do get the cutoff cleared. You need at least 2 out of 3 tests, right? So just APTT prolonged doesn't qualify this particular patient into an antiphospholipid syndrome. So this is just a DVT, a proximal DVT that has developed from a prolonged flight standing, right? So here, till what time you should get this, the duration of anticoagulation is something that has not actually been focused upon. If you see the question clearly, the first says rituximab, right? So rituximab, again, it's kind of trying to make you think about APS, while APS has not been clearly mentioned. Second is warfarin lifelong. Again, that would have been true in certain circumstances, but not here. And this one is again lifelong aspirin. That also does not make clear sense, right? So this is what our recommendations via international consensus. If you go to the American Society of Hematology guidelines, there is ISTH guidelines. There are various guidelines which are not very clear, to be honest. Some say that at least every guideline says that minimum of 3 months duration should be there whenever there's a first venous thromboembolism, whether provoked or unprovoked. Then some guidelines say that if it is unprovoked, then you should go for 6 months of minimum. That is what we are considering here. There is no proper provocation that is there except for prolonged flight. So here you option is not there of 6 months. If it was 6 months, then also that would have been a right answer, right? So here that duration is not being tested upon. Duration is being given in all the options, but the main thing is, do you want to give lifelong or not lifelong? That is what is the main question. And because this patient is not fitting into antiphospholipid syndrome, you should not give the patient lifelong aspirin. Only if there is something like uncontrolled cancer, proper factor V Leiden mutation, APS, antithrombin deficiency, hereditary abnormalities, multiple VTs that are happening. And these are also very much conditional recommendations. These are not standard gold standard guidelines or anything. If you go through up to date, if you go through your standard American Society of Rheumatology guidelines, also there is no clear cut consensus that when to give lifelong and when not. 3 months is the minimum preferred duration. Longer duration is needed in some certain groups, like whenever there is pregnancy associated VTE, cancer associated VTE, unusual site thrombosis, recurrent multiple thrombosis occurring, persistent risk factors like your prothrombotic states, thrombophilias, then you have to give prolonged anticoagulation. That is what the guidelines say in general. But yeah, even if these were there, then you could have considered the lifelong option, but they are also not there here. Yeah, so revised Sapporo classification criteria, very important. This is something that has been asked before. Also, it is asked very frequently in rheumatology, of course, but in your general medicine also, it can be asked. Then there is also this 2022 ACR ULR classification criteria that has come up for APS. This has been asked 2 to 3 times in the last 2 to 3 papers itself. I think every time they're asking this question. In your specialty rheumatology, till now in your general medicine for your INA, it has not been asked, but just I'm putting it out there because there is a possibility, there is a little bit far-fetched possibility that this can be asked. At least the main things you can remember, they've divided into clinical domain and your lab domain separately, and entry criteria is that at least one clinical domain and at least one lab domain has to be there. And for the patient to be classified into APS, 3 points from clinical and 3 points from APL domain. This is what you need at least, right, for a classification into APS. This is a little bit much simpler than the previous question. Which of the following is not a feature of seronegative spondyloarthropathy? So seronegative, do not get confused. Seronegative basically means it doesn't have RFACCP. Zero doesn't mean HLA-B27 or anything in this particular scenario. Why is it called seronegative? Because initially, when the arthritis were being classified, initially seropositive was referred to RFACCP positive, which are basically rheumatoid arthritis. Seronegative were classified into seronegative rheumatoid arthritis, some of them which are there, and seronegative spondyloarthropathy, right? So inside that, which is not a feature. Understand this arthritis is not your sacroiliac joint involvement, because some of you may think sacroiliac joint involvement also there is a symmetry. If you do not remember this, it's much easier, but if you get confused, then there is a problem, right? In sacroiliitis, in your predominantly axial spondyloarthropathies like your ankylosing spondylitis and enteropathic arthropathy, here you have symmetric sacroiliitis, while in your predominantly peripheral spondyloarthropathy like your psoriatic and your reactive, you have asymmetric sacroiliitis. This is about sacroiliitis. But arthritis, predominantly peripheral arthritis, what he's talking about here, this is lower limb predominant, asymmetric, and it is a type of oligoarthritis. And this can be predominantly erosive and inflammatory more than non-erosive. So this is the type of arthritis that is there. And others are obviously not a feature. Negative RF is directly a feature. That is what basically seronegative means. Strong association with HLA-B27, fair enough. Again, strong is not a very specific word, but fair enough. Uveitis, obviously there is an association, right? Yeah, so this is another a little bit of a controversial question. I'm not sure if this was given grace marks or something. See, basically AL amyloidosis was asked. It's not just amyloidosis that was asked, right? So which is not seen in AL amyloidosis, stroke, lumbar radiculopathy, autonomic neuropathy, and sensory motor neuropathy, which is limb length dependent. So these two are definitely there. There's no doubt about it. These are the more prominent manifestations. So the main confusion was among stroke and lumbar radiculopathy. Among the other two, lumbar radiculopathies are the ones that are more typically described with AL amyloidosis. Just to remember, because this is a previous year question. If this was not a previous year question, we would not be discussing it like this. But because it is previous, just remember AL amyloidosis, lumbar radiculopathy was asked. And this is slightly better because it is classically described, the radiculopathy is classically described with AL and ATTR amyloid, right? But when we talk about stroke, it is more often discussed not with your AL amyloidosis, but with your cerebral amyloid angiopathy, right? So that also, and also sometimes stroke may occur because of a cardiac involvement leading to thrombus formation, that leading to emboli, and embolus leading to your stroke. So those are the mechanisms by which stroke occurs in your AL amyloidosis. In your SA amyloidosis or your cerebral amyloid angiopathy, in your AL amyloidosis, it can occur, and it's not like it cannot occur, but a better answer would be lumbar radiculopathy, which is more typically described in these cases. So in AL amyloidosis, obviously we know the images that are asked. This is one of your NEET SS question. Macroglossia is there. Nervous system, the two main predominant manifestations apart from your carpal tunnel syndrome does occur because of your soft tissue, impingement that occurs. Then your peripheral sensory motor peripheral neuropathy occurs, and your autonomic abnormalities occur. So AL amyloidosis, that those are your common ones, but also you should remember that lumbar radiculopathy can occur. If they ask you stroke is more common in which of the following one, then it's better to remember that it is caused by A beta amyloid more than AL amyloid. Then coming to the next one, I know the previous paper was a little bit confusing. This one was much easier. So here, false about vasculitis, obviously HSP or inoculum purpura or IG vasculitis. It is not an ANCA associated vasculitis. It is a small vessel vasculitis, but it is not ANCA positive vasculitis. Right. So other options may be a little bit difficult. So most common death in EGP is serious related mortality. That is correct. Anti-PR3 positivity is associated with relapsing disease. That is also correct. And tracheal subglottic stenosis, which is seen in GPA, that can be identified on X-ray. That is also correct. So needless to say, this is a very basic image that we usually discuss. Small vessel vasculitis is classified into ANCA associated and non-ANCA associated, or what we call as posse-immune vasculitis. In your posse-immune vasculitis, you have your ANCA positive vasculitis and your immune complex mediated vasculitis. You have inoculum purpura, you have your Goodpasture syndrome, cryoglobulinemia, and other diseases, right? SLE vasculitis and other CTD associated vasculitis, all of that comes into your immune complex vasculitis. While your posse-immune, where there are not so many of immune complex deposits, it's more of antibody mediated, and that antibody is your ANCA associated antibody. So yeah, this is the main difference. In your MP ANCA, it is usually renal limited, CVS disease is more and worse survival compared to your PR3. So sometimes we think that PR3 involves the ENT system, it involves the lungs, so it might be very bad prognosis. Yes, it is bad. It's not. It's not that the prognosis is very good or something, but because of significant worse renal involvement in your MPO ANCA, actually the mortality is much more worse in your MPO ANCA. While in your PR3, it is more of relapsing disease that occurs, more of debilitating in terms of the organs that are involved, yes, but mortality is actually more in your MPO. So this time they did focus upon the relapses part. Next time they may ask you about which has a worse survival or where the mortality is more. Yeah, so this is the question that was asked. Cardiomyopathy is the strongest risk factor for mortality in your EGPA. This was a very simple question. The most specific sign is your ophthalmoplegia, jaw claudication. These are your two most specific signs for your giant cell arteritis. So needless to say, this we've discussed in detail in our lectures also. So, and needless to say, you can pause and look at this if you want. This is a good summary of your giant cell arteritis, halocine, etc. Everything we have discussed, polymyalgia rheumatica association, etc. You would know. Then again, this is an important question, not just the question, the solution is very important here. Questions are asked from this particular table a lot of times. This is actually given in your one of your initial chapters of your arthritis in your Harrison's only, the introduction to arthritis chapter. So they are drug-induced musculoskeletal conditions. So gout is important, drug-induced lupus again. In your rheumatology, in the same, approximately same paper only, I think, it was asked which of the following is the most commonly implicated drug in your drug induced lupus. So the answer is procainamide, right? So obviously that they may not ask you in your general medicine, but this particular list is very important for your gout, for your drug-induced lupus, tendon rupture, especially quinolones, very important, isotretinoin, very important, statins can cause, aromatase inhibitors can cause. So this particular table, they've been asking this since a long time, like last 5-6 years. So if anything comes from this, then just expect that yes, I should have read that, right? So myopathy, drug-induced myopathy, that we read in our neurology as well, in rheumatology as well. As you see here, arthralgia is not specific. Arthralgia is one you can kind of ignore, but again, if they ask you, who's to say, right? So in drug induced lupus, the main thing that you should remember is your PPIs, and sometimes there is also a possibility that your diltiazem can cause. So these two are important ones. In this osteonecrosis, that avian risk factors, mainly steroids, alcohol, these are your two main risk factors there. Osteopenia, we read via the drug, right? Whenever we read about phenytoin, we read about osteopenia. We know that PPIs can cause osteopenia, steroids will cause osteopenia. Heparin also, whenever we read about the side effects, osteopenia, osteoporosis comes. So these are your important ones. Psoriasis, I don't think they'll ask this. They may not ask this, but still, it's important. This table is very important. And as I told you, vasculitis, this was where the questions were asked. Minocycline is one of the most commonly implicated drugs. See, they put it last in this particular list, but actually it's one of the more common implicated drugs. So this is one of the tables which I think you should read just before the, one day before the exam or just before the exam. So this is one table which you should not ignore. Raynaud's also, if you look at it, most of those drugs are whatever causes vasoconstriction leads to Raynaud's. Scleroderma, again, needless to say, very, very important list. This list is very important. If they've asked you minocycline vasculitis, much more important is your bleomycin, vinyl chloride, pentazocine. This has been, it's a very popular quiz question also. So this table, whole table as such, is quite important. We have discussed this in our group also. We've discussed mnemonics for this group also in one particular chat just a few weeks back. So if you want to, go back and look at that, you can do that as well. So this again, I'm not sure if this is a rheumatology side question or it's a hematology question, but this is being discussed in rheumatology circles a lot. So we'll just go through it a little bit. So Erdon-Chester disease is myeloid proliferation, but it is non-Langerhans cell histiocytosis. So histiocytes, which are basically macrophages that have entered the tissue, but they're not Langerhans cell. Why are we specifically discussing? Because we have to look at certain markers, right? Certain markers which are specific to Langerhans cell, they will, if they are positive, then we think about LCH. LCH is a big spectrum, right? We know those triads, literal Suet disease, granulomas, everything. So that is a different spectrum, while this is a non-Langerhans cell histiocytosis. So here it's a clonal proliferation of myeloid cells where there is BRAF 600E mutations that occur, somatic mutations, and any component of the MAP kinase signaling pathway also there is a involvement that is there. So this and also there is also Vexus syndrome. These are two syndromes, that is a sort of vasculitis. So these two syndromes are the ones which are seen in old males. If you remember, IgG4 disease also somewhat it is seen in males slightly more than females, but there also it is elderly, 50 to 60-year-old is what is there. So the main symptoms here are neurological symptoms, bone pain, basically osteosclerosis occurs. So that was basically the wrong statement here. Multiple lytic lesions was mentioned. It is sclerotic. It's an osteosclerotic disease that can cause neurological abnormalities, bone pain, diabetes insipidus, constitutional symptoms. Obviously, these are the main manifestations that do occur. So this is again a slide that is to show that this is basically everywhere it is going, causing sclerosis. It's something like IgG4 related disease only. IgG4 related disease, everywhere there is fibrosis. Similarly, here there is osteosclerosis with foamy histiocytes on biopsy. And very important to remember, there will be positivity of CD68. So CD68 positivity will be there, but CD1A negativity will be there. So this is again, I'm not sure if they will ask you, but remember, because CD1A is specific, CD1A S100, CD207, these are specific to your Langerhans cell, while your CD68 is more specific for your histiocytes, which are seen in Erdon-Chester. So CD68 will be positive, while your CD1A will be negative. And it can involve the cardiac tissues, arterial tissues, endocrine, anywhere in the body that can be involvement. Aortitis can occur, periarterial thickening can occur, vascular ectasia, stenosis, all of these things can also occur. So this is again something that we read through our MBBS, something that every doctor should know. Anaphylactic dose in adrenaline, it not just 0.5 mg, it can be 0.3 mg also, 0.3 to 0.5 mg. Usually we give 1:1000 dose. So this is, I've put it into rheumatology because this anaphylaxis chapter is given in rheumatology. So intramuscular administration of 0.3 to 0.5 ml of 1:1000, which is the main question, right? 1:1000 is the main question. Then 50 versus 500 is main question, and IM, or sometimes you can give subcutaneous also. IV you should not give. Then you have the next paper, which is also, I think, a little bit similar, only it was not so weird as compared to the first paper that we discussed. So ray pattern, versus row pattern. So whenever you have uh, forgive me for my drawing, but these are suppose 5 fingers. If one finger is involved, that is ray pattern, right? Ray looks like this. But if there are one particular joint, so these are your DIPs, PIP. If this particular pattern is there, this is the row pattern. So this is the ray pattern, while this is the row pattern, as simple as that. So when is one particular finger involved, where there's no and also DIP is also involved, it is psoriatic arthritis, right? So basically ray pattern is seen, asymmetric ray pattern is seen in your psoriatic arthritis compared to the symmetric row pattern that is seen in rheumatoid arthritis. And obviously that was given in your Harrison also. I think this was a direct question, the direct line that was taken from your Harrison's only. Then again, very, very simple question. This was, I think, in the paper, the simplest question, which HLA is associated with Behçet's. So nothing was asked. HLA B51 is obviously the answer. It's actually not a very much diagnostic test also. It's in 20% of normal population also. It's seen more so in the USD studies are based from, but yeah, so found in 20% of normal population in North America, that is also there. So they just asked association. If it was diagnostic or something, maybe there might be confusion, but there's no confusion here. So CW6 is associated with psoriasis vulgaris, so that is also there. HLA-B51 is associated with Behçet's disease, no doubt, no doubt about it. So this is again a little bit of an overlap between maybe hematology, maybe infectious disease, maybe immunology a little bit, but I've just put it because immunology, obviously granuloma, types of granuloma is important. So fibrin ring granuloma is seen in Q fever, right? So just remember the types of granulomas. Epithelioid cell granulomas, where the macrophages are modified into these epithelial-like cells. So those are epithelioid cell granulomas, which are usually seen in TB and sarcoidosis. They are quite non-specific. Caseating or necrotizing, where the central area of that particular granuloma will be completely necrotized. That is seen in TB and fungal infections. Non-caseating, remember, can be seen in TB. It's not like they cannot be seen, but they're more kind of typical for sarcoidosis and Crohn's. Fibrin ring granuloma, what does it mean exactly? That there is a granuloma and surrounding that there is a ring of fibrin. This is what is fibrin ring granuloma. And allopurinol and Coxiella Q fever, both are very, very important. So rest are also important. You can just go through them. Stellate granuloma and this Dirk granuloma in cerebral malaria, this may be, as these are more of your NEET PG pathology questions. But again, when fibrin granuloma has been asked, obviously Dirk granuloma can also be asked. So can stellate granuloma, which is seen in Cascade disease, LGV, etc. Right. So these are all very important also, because now it's a repeat topic, right? So yeah, this is a little bit conceptual. Which of the following is defective in hereditary angioma type 1? So this is given in your Harrison's, and I'm not sure, I think it's given in that anaphylaxis angioedema chapter. Maybe a little bit difficult, but an important topic nonetheless, right? So what is happening here? Angioedema can occur because of bradykinin. Angioedema can occur because of your histamine, right? So whenever it's histamine, it's very simple. It's a kind of a type 1 hypersensitivity. You have to give antihistaminics. You can give leukotriene inhibitors. You can give epinephrine, steroids. All of those will work. But what is bradykinin, right? So bradykinin is there in the body. Sometimes it's produced naturally in the body. The body actually has a lot of mechanisms to stop that particular process. For example, bradykinin essentially comes from kallikrein, and kallikrein comes from prekallikrein, right? So here prekallikrein again comes from your C1 activation via the factor 12, 12A and plasmin. This is the basic pathway that occurs. Eventually bradykinin forms. Bradykinin binds to this bradykinin 2 receptor, causes endothelial vascular leakage, endothelial cell separation, vascular leakage, and eventually angioedema occurs. So this is what is your pathway of bradykinin mediated angioedema. Now, what is happening here is your main molecule is this one, C1 inhibitor. So C1 inhibitor is basically stopping, you're seeing the dotted lines here, right? It's basically stopping this particular pathway. It is not allowing bradykinin to be formed. So bradykinin is not able to go bind to its receptor and it's not able to cause bradykinin mediated angioedema. So this C1 esterase is actually a good thing, right? Because it's not allowing the body to have bradykinin angioedema. When that is absent, what do you call it? C1 esterase inhibitor deficiency, right? So when that is absent, then you basically get increased bradykinin, and that basically goes and causes bradykinin induced angioedema. This can occur via drugs also. There are a lot of drugs. These drugs, what they will do is they will inhibit bradykinin degradation. So after bradykinin is formed, there are few enzymes like your NEP, aminopeptidase, carboxypeptidase. All of these are causing bradykinin degradation. Though there also some NEP inhibitors, viltagliptin, all of these can go and inhibit those particular bradykinin degradation enzymes. So that is one pathway via which bradykinin angioedema is prevented. Others is via directly C1 esterase inhibitor. So when this C1 esterase inhibitor is deficient, then there will be bradykinin induced angioedema. So what happens when there is C1 esterase inhibitor deficiency, right? So infusion of C1 esterase inhibitor you can give directly, or a monoclonal anti-plasma kallikrein antibody you can give. That is basically lanadelumab. That is one option. Then you have other two options which are a little bit more older than your lanadelumab and your recombinant C1 esterase inhibitor. These are ecallantide, which is directly going and inhibiting the kallikrein. Kallikrein won't be converted to your bradykinin, or you can give the receptor blocker, bradykinin receptor 2 blocker, that is icatibant, right? Then epsilon amino caproic acid is also an antifibrinolytic, which we usually use as tranexamic acid. That also is contraindicated in patients with thrombotic tendencies, but it can be used for these patients in preoperative prophylaxis. Then we come to the type. So type is very simple here. Type 1 is quantitative, type 2 is qualitative of C1 esterase inhibitors levels, and type 3 is a different mutation, different change that occurs in factor 12, plasminogen, angiopoietin, kallikrein, all of these surrounding components, not the C1 esterase inhibitor per se, but kallikrein, all of these factors, when abnormalities occur, that is what is type 3 hereditary angioedema. So type 1, quantitative, low levels, it's the most common. Type 2, it's qualitative, dysfunctional protein is there, mutation in this SERPING1 mutation occurs, that leads to your dysfunctional protein, that is type 2. And type 3 is a separate proteins are defective, not the C1 esterase inhibitor. Evaluation algorithm, not so much important from a general medicine perspective. The main thing that is usually asked in your rheumatology again is the difference between type 1 hereditary angioedema and your acquired angioedema. Just remember it, don't go into the details. That C1q levels are decreased in your acquired angioedema, while in your hereditary angioedema it is normal. That is one thing that you can know. Then coming to more recent ones, the May 2023 paper, again, this was a little bit tough. So here lupus nephritis disease activity is best assessed by. So ANA, obviously it's not specific for your disease activity measure. Proteinuria, again, not specific. Yes, you can say that more the proteinuria, more you expect disease activity to be, but it's not a very good specific marker. The main confusion here at that point was between this particular option and this particular option. But the thing is, complements are not specific. Complements can be low infection also, sometimes immune complex mediated disease, in some other vasculitis also it can be low, while your in pregnancy changes can happen, etc., etc. While your dsDNA and sometimes your, if you look at C1q levels, sometimes they also correlate with your vasculitis, nephritis, etc. Those are much more specific to your lupus nephritis. Best is obviously dsDNA only. So that is what is the best answer. So complement levels should not be automatically interpreted as a part of disease activity, or if they're normal as disease questions. That's not how it should be. They are modified by various factors. dsDNA, however, is quite specific, and it can be used to take it as a marker for disease activity. There are multiple other markers. There are various prognostic markers, various disease activity markers, etc. But among those, for lupus nephritis, anti-dsDNA titer is very good. Then this is again a very simple question. If you know that what is macrophage activation syndrome, the first thing that you would read about macrophage activation syndrome, or what we call a secondary HLH, secondary hemophagocytic lymphohistiocytosis, is that there are cytopenias. So there's no thrombocytosis. In your inflammatory disorders, maybe not your SLE, Sjogren's, etc., you see leukopenias, but vasculitis, arthritis, you see majority, you see thrombocytosis, leukocytosis, because it's in a hyperinflammatory state, right? Similarly, in your systemic onset GIA, you will see thrombocytosis, leukocytosis, but when macrophage activation syndrome develops, then you see cytopenias. You see cytopenias, impaired NK cell activity. Obviously, this is the basis of your etiopathogenesis. Transaminitis, hypofibrinogenemia, hypertriglyceridemia, severe fever. You can see CNS abnormalities. All of these are what you can see, right? So this is from your HLH. So hyperferritinemia, again, the most important one. All of these are abnormalities that you see, and this is your, I think, this is a Ravelli criteria for your mass macrophage activation syndrome in your systemic onset GIA, where you have a febrile patient and you classify as mass if firstly ferritin. Again, the numbers are not important from a general medicine perspective. If you're preparing for rheumatology, yes, these are important. So ferritin 684, platelet 1.81 lakhs, less than. It's not more than. There are cytopenias, less than. AST more than 48, triglyceride more than 156, and fibrinogen decreases, hypofibrinogenemia occurs. Also remember one important associated concept here: because fibrinogen is low, the RBCs are not able to attach to each other, not able to form a roulet, and hence actually ESR falls, right? So this is also very important. Then which is not true about IgG4 related disease? Good response with steroids. Okay, fair enough. Steroids are the first line drug and usually they respond well. Steroids plus antifungals are used. Again, does not make sense. Antifungals, they have no direct role in your IgG4 related disease. Pseudotumor formation is a feature. Yes, chronic sclerosing sialadenitis is a feature. Right, so IgG4 related disease is a newly discovered disease. Initially, there were a lot of these tumefactive, fibrosing, sclerosing. Sclerosing is not the very good word. Fibrosing is a very good word. All of these fibrosing inflammatory diseases, fibroinflammatory diseases, they were given separate names. Now they've been all clubbed into your IgG4 related disease. Mikulicz syndrome, where you have your salivary gland involvement, parotid, lacrimal gland involvement. Then you have autoimmune pancreatitis. Now it is being, there are again type 2 types. Type 1 autoimmune pancreatitis, which is more common. That entire thing has been put into your IgG4 related disease. Hypophysitis, thyroiditis, specifically renal thyroiditis, interstitial pneumonitis, interstitial nephritis, prostatitis, all of these are slowly, lot of patients which were initially just kept as, for example, aortitis under evaluation or something, all of these are slowly coming into your IgG4 related disease. So you have tumefaction, you have elevated IgG4 concentration, tissue infiltration that occurs by IgG4 positive plasma cells. So this has been frequently observed in middle-aged to elderly men, and its clinical symptoms are relatively mild with good response to steroids, and IgG4 to normal IgG cell ratio is usually more than 40%. This is one of the indicators. So you have obliterative phlebitis, you have storiform fibrosis, and fibroinflammatory infiltrates, tumefaction, all of these are there. So they can be treated effectively, they have good response, but in 25 to 50% will relapse. Relapse doesn't mean response is bad, right? They can relapse on low maintenance dose, and you may consider the next line is usually rituximab. So again, I'm not going to do the details. There are subtypes of IgG4 which are not important from a general medicine point of view. So type 1 is usually your pancreatic or hepatobiliary. Type 2 is basically your abdomen, aorta involvement, retroperitoneal involvement, and type 3 is your head and neck involvement. So these are your various types, and a lot of plethora of organs can be involved, and in all of these can have respective fibroinflammatory phenotypes in each of these organs. So that is how this whole disease manifests. So, which is not true about spondyloarthropathy. Again, we discussed in that particular example, again, same question. If you look at it, spondyloarthropathy phenotype, same, very similar question, right? So, there also I discussed lower limb predominant peripheral erosive arthritis, asymmetric arthritis. This is what we discussed, right? So, it's a non-erosive arthritis is not a true statement. It usually occurs in young males, HLA-B27 association, presentation rare after 40 years, almost the same question, right? So yeah, so these again, no need to remember for a general medicine person these criteria names, but just to remember what the phenotype of your lower inflammatory lower back pain is. It is important. Remember, young male, early morning stiffness, axial early morning stiffness more than 30 minutes. Peripheral can be more than 45 minutes. Duration of back pain should be chronic, that is more than 3 months. Insidious onset, nocturnal predominant pain, improves with activity, worsens with rest, all of these. A good improvement with NSAIDs, family history, all of these are your classic signs of your inflammatory lower back. So erosions obviously will be there. Juxtafoveal osteopenia, ankylosis can occur. You obviously remember the modified New York criteria. There are 4 stages for this ankylosis. Initially, there is just blurring of the joint margin. Second, there is erosion, sclerosis. Third, there is pseudo widening of the joint space. All of that we discussed, right? So there also we remember that there are erosions that are happening at the joint margin. So erosions definitely do happen in your spondyloarthropathy, which is not true. Again, this is a little bit confusing because we don't really focus upon crystal arthropathy about the type of arthropathy. Firstly, because to be very honest, it's not very well characterized in papers or in literature, right? So but then again, they did ask a question, and actually they did take it directly from your Harrison. So this is your Harrison table where they mention spinal arthritis, where they mention this enthesitis. Tendinitis is common, but enthesitis is not very common. Actually, inflammation does occur in your enthesial areas because of the crystal deposition, but it's not usually described as enthesitis in literature. But still, Harrison has said that though, okay, you can call it enthesitis because essentially there's inflammation that's happening, but it's actually an indirect inflammation, right? So enthesitis is there, spinal arthritis is there, so you cannot mark this. Tenosynovitis is definitely there, that there is no doubt about. So these are obviously there, so they're not the option. Non-erosive is a little bit confusing because actually what happens in crystal arthropathy is erosions occur late. So non-erosive is not completely false, especially acute crystal arthropathy can be non-erosive. But obviously we know Martel sign, we know these punched out erosions, lytic erosions, all of that, Martel sign, G sign, all of that erosions do happen eventually in crystal arthropathy. So non-erosive, you can still consider it to be false. Next, very, very straightforward question, which is a medium vessel vasculitis, that is PAN, polyarteritis nodosa, needless to say. So primary vasculitis, secondary vasculitis. These also have kept it here because that particular image where types of vasculitis diagram that we already discussed a little bit earlier. So this, for this one, you better remember this also. So secondary vasculitis especially can be asked. Drug-induced vasculitis has been asked before, the minocycline question. So that is there. HCV causes cryo, HBV causes PAN more than cryo. Cancer can cause vasculitis. Other CTDs can cause vasculitis like SLE, RA, usually small vessel vasculitis. Sarcoid can cause vasculitis directly as well. So this is more of, I'm not sure if this is actually a rheumatoid question. This was taken from a paper, sorry, a Harrison page that is in your initial parts of Harrison where purpura is being described in your platelet disorders. So again, but still palpable purpura is usually associated with vasculitis, and options were also including cryoglobulinemia. So I put this here. So purpura, whenever it is palpable, consider either vasculitis, which is the most common cause of palpable purpura, the most typical cause of palpable purpura, but also emboli. For example, meningococcemia, disseminated gonococcal infections, Rocky Mountain spotted RMSF, ecthyma gangrenosum caused by Pseudomonas. All of these can also cause palpable purpura. So meningococcemia, obviously not. Gonococcemia, if it was given, could consider, but scurvy, meningococcemia can also cause. Gonococcemia, if it was given, that also can be there. I'm not sure of the fourth question, but scurvy definitely doesn't cause palpable purpura. It may cause non-palpable purpura. So which is false about sarcoidosis diagnosis? So hypercalciuria is the most, inside your electrolyte abnormalities, the most typical manifestation is your hypercalciuria, not even hypercalcemia. Hypercalciuria is usually more seen compared to even hypercalcemia, but hypocalciuria is obviously wrong. Raised ACE levels, one of the markers that is for sarcoidosis. BAL with raised CD, remember it's BAL, serum also shows, but BAL is the more correct one. BAL with raised CD4 CD8 ratio, raised ACE levels, hypercalcemia, these are definitely there. Hypocalciuria is a directly wrong option, right? So hypercalcemia and or hypercalciuria is seen in 10% of sarcoidosis patients. So this is a little bit difficult if you've not read your Harrison a little bit thoroughly. So myxovirus staining, what is this? So myxovirus is a protein basically. It's an interferon induced protein. So why is this called myxovirus and all? Is it because of viral infection? So what this is when this myxovirus does cause an infection in the body, it generates this particular interferon induced protein. So whenever there is viral infection, interferons get induced. When interferon get induced, antiviral proteins are generated. That particular type of protein is this myxovirus resistance protein A. That is what is myxovirus A protein, right? That has become the name of that protein. That same protein is released whenever these type 1 interferons are released. in any cause, that particular protein is released. So that is released in dermatomyositis also. So just by chance that same protein is being released, but because it is easily stainable, we are using it as a marker. So that is myxovirus resistance protein A, but that has not, it has got to do with myxovirus, but here we are not talking in that particular, correlate context, right? So here we are talking about it because we are using that same protein as a marker in dermatomyositis patients, because these patients are also producing the same protein. Why? Because here also type 1 interferon is increasing because of it's an autoimmune disease, right? So type 1 interferon is increasing because of whatever reason that is producing this particular protein, and we are using it as a biomarker. So we are using that particular staining in muscle biopsy samples in dermatomyositis. So that has been given in your, this is one of the most important, most high yielding tables in your Harrison. Go to that myositis chapter, the second page, it's there. One of the most high yielding ones, right? So in dermatomyositis, you would see positive myxovirus A or MXA, myxovirus resistance protein is staining, showing that the type 1 interferon pathway has got activated, characteristic of dermatomyositis. It can help differentiate between other myositis like your immune mediated necrotizing myositis, polymyositis, etc. Then coming to even more recent ones, this was a little bit controversial because they have not given the more popular ones. They've given tofacitinib, yes, very popularly notorious for causing reactivation of latent TB, but these are a little bit less known, right? But if you go through literature, it's not very clearly given in your Harrison. If you go through literature, there are good papers, strong papers that show that rituximab doesn't cause latent TB reactivation. It causes it causes hepatitis B reactivation. We all know that, but not latent TB reactivation. Again, there are certain strong papers, not all papers. Some papers are showing that is also causing some reactivation, and there are some case reports as well. But most strong papers show that rituximab is not causing latent TB reactivation. While in your Harrison, if you see anakinra, so the main confusion was anakinra and abatacept, the co-stimulation, right? So anakinra clearly given reactivation of latent TB can occur, and this is another one that there was a consensus paper showing when to screen in what biological, latent TB, how to screen, etc. There also, if you look at it, the highest risk are JAK inhibitors, tocilizumab, and your TNF alpha. Just remember TB, TTT, right? Just tofacitinib, TNF alpha, and tocilizumab. That's as simple as that. That's done. Then comes the other one. So here, if you see, your abatacept is also given in among the higher risks only. So as such, it's lower risk, but it's not no risk, right? So abatacept is definitely there. Then you have anakinra also, which I showed you, and here also IL-1 is there. But rituximab is not showing a risk in your reactivation of your latent TB. Again, it's a difficult question because this is not something that is very strongly propagated. There are centers where before giving rituximab also we do screen for latent TB because we're not sure, right? That's not, these papers are not as like a gold standard papers, right? So that's why there's not 100% surety, but still among these options, definitely the best answer was rituximab. TB testing not required, latent TB testing not required. So, preventive TB therapy is required definitely when you are starting all of these drugs. These include abatacept, anti-IL-1, which were the main confusing options. So, which can be used in periconception. Again, very, very poor question, I would say, because evidence is not good. Especially see belimumab, anakinra evidence is good, but rituximab evidence is not there only. Golimumab, again, in some particular papers, it has shown that it is good. That is why it's the best answer. There's no doubt about it that it is the best answer here, but again, evidence is not very, very strong. So TNF alpha inhibitors are among the safer drugs. We're not sure because they do, especially when you give them in third trimester. The issue is not with respect to teratogenicity or sterility or arborifacients or something. It's not causing abortion, it's not causing teratogenicity, but what it is causing is it's going into the fetus, it's causing immunosuppression there. That is main concern that we have whenever we give TNF alpha inhibitors. While rituximab, etc., we don't know at all. The evidence is very, very poor. So which is minimal risk? Calcineurin inhibitors are very good. HCQ, sulfasalazine, quite safe. IVIG and fractionate heparin, aspirin, obviously they are given as treatment in your APS, so they are also safe. Low to moderate risk NSAIDs, few of them, especially in your third trimester, what happens is it causes closure of your patent ductus arteriosus. So there you have a little bit of issue. Prednisolone is given, not that it's not given, but slight issue with respect to low birth weight, etc. has been seen. Azathioprine, calcineurin inhibitors, pretty much safe, low to moderate risk. Then you have TNF alpha inhibitor. So this is why TNF alpha is usually considered as a low risk, and that's why among these can be used was the question. And among these, yes, it can be used. So can colchicine. Which to be never to be used? Methotrexate, never to be used. Leflunomide, you should use washout. Actually, you should. It's very teratogenic. Congenital anomalies are massive. Cyclophosphamide, not to be used. MMF, not to be used. Warfarin, obviously teratogenic. So this is about the high risk, which you should obviously 100% know as a even an MBBS doctor, anyone who's dealing with following up patients who might be on these drugs, everybody should know this high risk one. But among the other options, golimumab is the lower risk. So if you see what are the other options, belimumab, it's unknown risk. Anakinra, nobody knows. Rituximab, nobody knows, unknown risk. So they've taken it from this table. This is a general medicine paper, but they've taken it from this table, which is actually in your Kelly's, right? So it's a little bit tough question, definitely. Maybe I'm not sure. Maybe you could have marked rituximab also. I'm not sure because it's in, I think, SLE chapter or somewhere it's given that rituximab can be used in pregnancy, which is actually not wrong because sometimes what happens, refractory disease, you have no other option. You can't give cyclophosphamide, which is the usual one, which is given in severe disease activity. MMF you can't give because it's, although it's needed in severe disease activity, you cannot give in pregnancy. So your option ends up as rituximab in in your SLE while pregnant, right? So yes, it can be given. It is given in many scenarios, but among these other options, golimumab is the one that is slightly better. Can be used, right? So this was matching skin lesions was with disease. Obviously, we didn't get the exact options, how they framed the options, we don't know, but this was the crux of the question, right? So cryptococcosis shows similar to molluscum contagiosum. It usually shows umbilicated papules. SLE malar rash, very simple. Then dermatomyositis, Gottron's rash, very simple. Sarcoidosis, one of the, it's not very common, but chronic sarcoidosis, one of the common skin manifestation in lupus pernio and lupus vulgaris. Lupus vulgaris has nothing to do with your SLE. It's not nothing to do with your lupus pernio. It's usually seen basically. It's a type of cutaneous TB where you see apple jelly nodules, etc. So that is lupus vulgaris, right? So this was the matching. I'm not sure how they framed the question, but this also you should remember, right? This explanation, nothing separate new. Yeah, so this is the most recent paper. So yeah, so this was weightage, exact weightage, which is least weightage was asked. I think this was one of the previously asked question only, but initially it was asked in your INSS rheumatology portion. Now they have shifted it to general medicine portion. So maybe I'm not sure what kind of Q bank they have, but yeah, least weightage is in your 2019 ACR Euler criteria. Luckily, they have kind of put this into your Harrison. Earlier, it was not there. The new Harrison, this is there. So, as you know, the highest weightage are usually for your nephritis. The renal class 3, class 4 nephritis is usually having the highest weightage of 10. And your lowest weightage are the first ones that are there in each domain. Constitutional domain, you have 2. Then you have hematological domain that starts with 3 with leukopenia. Then only delirium is there. Then you have 2. I think this, because it's a repeat question, you can just go and remember these two, or if you possible, you can remember the entire scoring, or at least remember the highest one. Highest is renal biopsy, 3 or 4 class. Then you have lowest, which has this fever, constitutional manifestation, delirium, non-scarring alopecia, oral ulcers. These are also 2. Then you have positivity of your anti-phospholipid. These are your lowest 2 ones. So among this, lac will be the one which has the lowest scoring, that is 2. So this is your newest criteria where they have removed the word of nasal ulcers, DCT, direct Coombs test they have removed, and added this constitutional domain of fever. And among this, you basically need a total score of 10 to be classified as SLE. Entry criteria will be there where ANA positivity of 1:80, that is the entry criterion. After that, you should have at least one clinical domain, one lab domain, and when you add those points of at least 10 should be there. So not a risk factor for lymphoma. Again, this is a question that I focus upon a lot in every allied test, in every, whenever I teach. This is something that is very commonly discussed in conferences, in quizzes, very common question mentioned in Harrison also. So again, one obvious doubt kind of a trick was, is it neutropenia or lymphopenia? So which is not a risk factor? Neutropenia is a risk factor. So neutropenia and leukopenia, these are the two words that you should remember. These two are risk factors. This was not a very easy question because low C4 is considered a risk factor, but low C3 is actually not mentioned much as a risk factor. So RF positivity or Rho positivity, La positivity, RF positivity, basically antibody titer positivity, cryoglobulinemia, all of these are considered risk factors. So the mnemonic here is usually P2LC, where you have cryoglobulinemia complement low, that to C4 low, two C's are there. Then two L's are there. One is leukopenia, and the other is possibility of your tongue atrophy, L and T. And yeah, so P2 is for persistent parotitis, right? So persistent parotitis, tongue atrophy, you should remember purpura. These are your two P's. Then you have your low C4, cryoglobulinemia, seropositivity, and your leukopenia. Leukopenia, but not lymphopenia percent, neutropenia more than lymphopenia, and all of these cause extranodal low-grade marginal B-cell lymphoma, which are predominantly peripheral. So yeah, this is the main thing. Lymphadenopathy, splenomegaly, all of this are also predisposed to the actors association markers for your malignancy. Speckled pattern is seen in. So firstly, again, before speckled pattern, I always tell you, whenever there is an ANA pattern question, the main focus is usually on your nucleolar pattern, because this is something that we usually forget. So nucleolar pattern is something that you should always remember. THT0, PM, SCL, and your U3RNP. This is a little bit difficult to remember, and this is where the focus is upon. And here also same options were given. If you see PMSCL, THT0, U3RNP, because nucleolar pattern is neither fine speckled nor dense speckled, not dense fine speckled, there's no confusion. Once you put nucleolar pattern in the option, nobody will come and argue, is it fine, dense, nothing, coarse, nothing, right? So nucleolar, all of these are nucleolar. Directly RNA polymerase goes into speckled. So RNA polymerase is usually considered as a core speckled pattern, but still, even if you just say speckled also, that is also right. So this is from your systemic sclerosis chapter in your Harrison. So DNA topoisomerase looks like homogeneous, can be called speckled or fine speckled also, or sometimes in, if you look at the proper ANA guidelines, it's considered as a separate pattern also, topoisomerase pattern. Centromere, it's also called zipper pattern or centromere pattern also itself, or discrete speckled pattern, whatever you want to call it. RNA polymerase 3 in speckled pattern. U3RNP, THT0, PMSCL, very, very important. These are nuclear pattern. Others are again speckled pattern. Type of hypersensitivity in SLE. One of the questions that was asked from your basic immunology, this we have discussed in detail in your hypersensitivity lectures. So basically, type 3 hypersensitivity, I told you to remember, three things are stuck together: antigen, antibody, and your complement. And once this immune complex form via the various, basically these immune complexes will go in the circulation, and wherever there is high filtration, where does high filtration occurs in the synovial fluid, where the synovial fluid is being formed from through the filters, and in the renal vasculature. So there the deposition occurs, and there it can cause synovitis, nephritis, etc. And there, once that deposition occurs, slowly there is activation of complement, slowly there will be much more of cytokine release, chemokine release, and inflammation, tissue injury will manifest there. So these are your type 3 hypersensitivities. Your various serum sickness is the most classical described one. SLE is very classically described. Post-streptococcal glomerulonephritis, pan, vasculitis, etc. are immune complex mediated vasculitis. Basically, those are all type 3 hypersensitivity. So those were the previous year topics. So if you look at it, the main high yield topics which you should not ignore, I feel, are more than SLE also APS. APS, at least because, especially because it's a small chapter, do not ignore it. SLE, I can tell you, yes, SLE questions have been asked, but by itself, it's a little bit of a big chapter. But at least what is given in your Harrison, I feel you can read that and go. It doesn't Again, depends. If you have read it very well before, it takes not more than 2 to 3 hours. But even if you go through our lecture, that should be more than sufficient, right? APS, very small chapter, high yielding, especially the new criteria that is there. That is something that the 2022 criteria, that is something that you can read just one day before, right? Then some other thing that we saw is your non ankylosing spondylitis, spondyloarthropathies. So this is something that is important in your NEET assess, in your INSS also. This can be repeated. Then vasculitis, as we initially discussed, there have been at least one question every year. So if you are preparing for cardiology, neurology, you should consider at least one question is coming from vasculitis, which is not a very big unit. You just those 10 hours of lectures, you can definitely go through that. You will 100% get one question. Even obviously, you've given your NEET assess recently, you would definitely find it not very much cumbersome to go through it, right? And here also remember, vasculitis, they're not going in depth into the management, etc. They're basically focusing on your basics, which is medium vessel, which is immune complex mediated. There only they're focusing. One question was a little bit difficult. That also the exact option HSP is an ANCA-mediated vasculitis. That was the option that you should catch, right? That doesn't need any in-depth reading. So vasculitis, if you're weak in vasculitis, just read the basics and go. Minimum that much is necessary. Then one thing that they are asking in a little bit depth is your drugs. So drugs, we have done this series, which is there on the app, pharmacology and rheumatology, that I've done from a not very difficult perspective, that I've done for medicine residents and rheumatology people, rheumatology aspirants. So as a general medicine physician also, when you're dealing with immunosuppressive agents, that will help you. And if you have a little bit extra time for your general medicine part, definitely go through that. Otherwise, see, if you do not have extra time, better leave that topic, because again, drugs is something that might take a little bit extra time. I'm not the vasculitis, I'm sure one question will come. Drugs, I don't know question will come or not, although they are asking, but they're asking a little bit in depth also. So that is one thing. If you have a little bit more time, you can go through it. Otherwise, completely forget it, right? So those are your main high yield topics, especially APS and basics of vasculitis. These two things definitely go through, right? So all the best. I think we have 4 weeks. The fourth Sunday from now will be the exam. So all the best, and you can always ask any of your doubts on our WhatsApp.